Welcome back to another episode of Palm Peeps. We are here with one of the last couple episodes from our ARDS summer series. And we've got a good rapid fire journal club for you. And here with me, as always during this series, is Dave Furfaro. Hey, Dave.
Hey, Luke, back again. I love it. Thanks for having me on the show. Much appreciated.
Of course. Yeah. Wouldn't talk about vents and ARDS without you.
Ever. I hope you're
Yeah,
always
never.
thinking
No,
about me when you do
no. I'm calling him on rounds constantly from Atlanta.
it.
All
I
right.
love it.
So today we're going to talk about DEXA-ARDS, which is an interesting paper that I feel like got lost in the shuffle a little bit just through a twist of fate. This was published in Lancet Respiratory Medicine in 2020. And of course, there was nothing else going on in critical care in 2020. And so this one, I feel like flew under the radar a little bit.
Yeah,
It is,
this paper has a very interesting lifespan of when it comes out and how it's received, and then it's post-COVID reanalysis. So I'm very excited to talk about it.
yeah. And in terms of just the background that this got published into, so ARDS is, as we all know, an intense inflammatory process that unfortunately does not have proven specific pharmacotherapies to treat it. Some previous work and a recent meta analysis had demonstrated improvements in inflammation, gas exchange, and ventilator and ICU liberation with steroids in patients with ARDS, but had not adequately addressed mortality.
Yeah, thanks, Luke. As long as there are critical care conditions out there, and as long as steroids exist, which will both always be the case, people are going to keep studying about when to use them, who are the subgroups of patients who are the most benefit. And so this ARDS steroid question has come up time and time again. I think previous to this, the study that gave people the most pause was a New England Journal study in 2006, looking at steroids in non-resolving or late ARDS that showed potentially increased mortality. And so everyone was very worried about using steroids in ARDS, but there continued to be this lingering thought about the high amount of inflammation. As you said, previous work, meta-analysis saying there must be some patients who could benefit. What if it was earlier on or done at the right time? This question will keep coming up in the future still. And this was a trial to aim to try to give us more information on that. So what did they do in this trial?
Yeah, so this was an investigator initiated, multi center, unblinded, randomized controlled trial in 17 academic ICUs in Spain that ran from spring of 2023 to December of 2018. Their primary outcome was vent free days at 28 days, and some key secondary outcomes were 60-day mortality, the actual duration of ventilation in ICU survivors, and then rates of ICU acquired infections. Steroids are immunosuppressing, and so you always worry about that as a potential adverse effect from the intervention. In terms of their participants, so they were including people with ARDS with a P to F under 200 for less than 24 hours on low tidal volume ventilation. They were excluding patients who already were receiving steroids or immunosuppression, who had bad heart failure or severe COPD, or patients who were DNR, interestingly.
Yeah, that is interesting that they had that as one of the criteria. Makes sense. We just don't always see it in these ARDS trials. The thinking about the actual duration of ventilation in ICU survivors is an interesting one. It's maybe getting to some of this study of fibrotic ARDS and is it having a more long-term impact. So I like that as a secondary outcome. The main thing I'll highlight here is just this unblinded nature. And we'll come back to this when we get to the conclusions and reception of this study, but it is an unblinded study that was investigator initiated. And so we will talk about the implications of that when we're thinking about the outcomes. Luke, I love your summaries of who we were including. When I'm thinking about how I can apply DEXA-ARDS, who were these patients in summer?
Yeah, so these were middle aged, mostly male patients with less than 24 hours of moderate to severe ARDS receiving lung protective ventilation without chronic heart or lung disease. And then, just in terms of some of the details of these two groups, the mean P to F was about 140. And then, like many ARDS trials, just over 3/4 of these folks' ARDS was caused by pneumonia or sepsis, which I think will be important when we talk about how to interpret the outcomes here.
Yeah, definitely. Thanks for highlighting that. One of the different ways we think about ARDS, one of the many different ways is about underlying etiology. So important to point these out. All right. So then we were going to talk about the interventions that they did for these patients so we know how we can apply it to our bedside practice. So, how many people do they get and how do they treat them?
So they enrolled 277 patients. They were stratified by center and then randomized. The intervention here was dexamethasone, 20 milligrams daily for 5 days, followed by 10 milligrams daily for 5 days. So 10 days total of steroids. It was stopped early if they were extubated before day 10, and they had to get the first dose no more than 30 hours after their P to F was under 200. So they were trying to get it into folks early. The control arm did not have a placebo. There was just standard of care. And then everyone was receiving low tidal volume ventilation.
Yeah. Thanks for going through that. I think a couple things that get pointed out in this trial that we can mention here. You pointed out again, non-blinded, no placebo. So these are things that are not always make a study irrelevant, certainly, but they are important limitations because we know that clinicians and researchers can bring biases to their studies. And then, in addition, this was a study that suffered from some very slow enrollment. There was about 3 patients a year on average at many sites. And so that doesn't always necessarily mean that you're having a selection bias. You could think about studies that are looking at rare events that take a long time. The Aeolia ECMO trial is one like that, where it just takes a long time to get patients in. However, it does make you think, are there a lot of ARDS patients out there that for some reason clinicians are not referring to this study? And that's why we're getting a lot slower enrollment. Luke, you always make sure that I'm honest on my statistics by telling us the power. So what was the assumed benefit of this study, the power, and what did they end up finding?
Yeah, so I always find it a little interesting. One, just to keep in the mind about whether maybe a trial was underpowered, but also I think it gives you a glimpse into the mindset of the trialists a little bit. Their power calculation with an N of 314, and again, they enrolled 277. They would have 80% power to detect 2 additional vent-free days and a 15% mortality reduction, which is a really big reduction in mortality. And as an aside, I think this seems to be a theme in some ICU trials, these really ambitious proposed benefits during power calculations, and then slightly under enrolling for the power calculation. And then you end up with a point estimate often that favors the intervention, but isn't quite statistically significant. And so I mention it just because I think it seems to crop up in ICU trials not infrequently and always makes it a little trickier to interpret things.
Yeah, it's interesting. I am by no means a clinical trialist. I think that not because I don't want to be, but because I just don't have the massive amount of skills that you need to do it. But I do think that when you're making this planning, it must be really tough because the smaller changes that you're trying to look for really affects the amount of patients that you're going to be able to enroll. So you want to have good, honest predictions and then be realistic. The power calculation you're getting for to have a feasible study. These are quite expensive studies. So interesting thing to point out.
Yeah, I'm not jealous of the folks making those decisions. I feel like I'm much more comfortable throwing stones from my glass house about trying to balance both powering something adequately that it's useful and you think you could find a benefit, but also a trial that could be realistically done and enroll enough people in a realistic time frame. So that I am not envious of those difficult discussions.
Yeah. We're like the casual people watching the Olympic gymnastics. We're on the balance beam technique.
Right. I'm the guy watching water polo and saying, that looks like it might be hard.
Yeah. So
Okay.
what did we end up finding in this study?
So, in terms of efficacy, the 60-day mortality outcome was actually really positive. So, there was a 21% mortality in the steroid arm versus 36% in the control arm, with a p value of 0.0047. That gives us a number needed to treat of just under 7, which is like really impressive in terms of ICU interventions. In terms of vent-free days at 28 days, that also favored steroids, the dexamethasone arm. So it was 12.3 versus 7.5 vent-free days at 4 weeks. And then the actual duration of ventilation in ICU survivors went in that direction too. So 14.2 days in the steroid arm versus 19.5 days in the control arm. Whenever we're talking about giving folks steroids, there is a safety concern in the ICU and more generally. And interestingly, rates of hyperglycemia were not meaningfully different between the two groups. So there was a point estimate of higher hyperglycemia, 76% versus 70%, favoring the control arm, but that was not statistically different, which is interesting in a steroid trial because we know steroids cause high blood sugar. And then there was no difference in ICU-acquired infections, which is always my other concern when we're talking about something that's potentially immunosuppressing.
Yeah, I think to work even backwards, I want to talk a lot about the efficacy, but from the safety, I think from a lot of trials we have now of steroids in the ICU for different indications, sepsis, ARDS, I think it's pretty clear that in aggregate, they're pretty safe. Infections and hyperglycemia, sometimes mortality or bleeds that people think that they look at in an aggregate signal in these randomized trials, we really just don't see that much. That's not to be said that there are some patients who could get bad infections and it all depends on the substrate underneath, but we get more and more evidence when we get these trials that steroids can be used safely if they're indicated. And this is a huge impact on 60-day mortality and vent-free days. The vent-free days is enormous. It's almost in half, right, that they're cutting
Right.
the duration of ventilation. I think that the benefit was almost so big when this study first came out that people weren't sure if they should believe it. Like it was so
Right. It's like too good to be true.
that's what it felt like. And when we talk about this reception of this trial, I think that there was a thing when it first came out that we had talked about steroids in ARDS a lot. It was a relatively small trial. I think appropriate for ICU studies, but relatively small. This benefit seemed enormous. And then people turned to some of those things like slow enrollment, like an open labeled study, no placebo, wondering if it was too good to be true. And then I think the interesting thing to take away is that in a very different circumstance during COVID and the RECOVER trial, and looking at dexamethasone in hospitalized patients with severe COVID, or sorry, the recovery collaborative trial that they were looking at was much bigger study, but also had the same thing was that this was open label also. Now that's a study of 2,100 patients, and this is a study of 200 patients. So maybe you're more reassured by those large numbers. But I think that the study design flaws that people were worried about in this study were tolerated much more in that other study. And then obviously dexamethasone for patients with hypoxemia and COVID became the standard of care. And I do think that this sort of snowball effect of this study coming out right before COVID, the impact of steroids of COVID is part of what led to the changes in some of the ARDS guidelines. It's important to note that the ATS and ERS guidelines differ somewhat on this point, but more enthusiasm overall for steroids and ARDS as a combination, I think, of these sort of serial events.
Yeah, and I totally agree. I feel like COVID was just a really big example that sometimes tamping down inflammation is really beneficial, just depending on what's causing somebody's respiratory failure. And that's part of how I think I parse this trial. And this is maybe like a little bit of a soapbox on my part, but I think this is a really good example that like ARDS is not a disease, it's a syndrome or a kind of almost final common pathway of a bunch of different things. And so sometimes I wonder whether differences in the underlying cause of someone's ARDS explains the kind of seesawing we see in these pharmacotherapy trials in ARDS. You can imagine someone who has ARDS from pancreatitis may respond differently to a drug than someone who has pneumonia or someone who has the flu or someone who has sepsis. We know certain other conditions that can cause ARDS are inherently steroid responsive. Cape Cod is a great example of bad pneumonia, community-acquired pneumonia getting better with steroids. So I do wonder sometimes whether that is part of what explains the kind of back and forth we see with some of these trials.
100%. And I think one of the ways to put together what you're saying is about phenotyping and precision medicine. And this is a huge move in ARDS now. If you guys haven't listened, we have had a couple episodes with Dr. Caffey. We've had one on ARDS precision medicine and phenotypes. We've had one about the future of ARDS research, and I encourage you to listen to us if you're interested in saying, yeah, that's true. What is the different phenotype? Is it based on etiology? Is it based on host response? Is it based on everything? And do they change over time? The answer probably also could be yes. And that ICU critical illness is dynamic. You basically already gave it to us, Luke, but I'll ask you for it one more time. So when you take away this study and you're pull it out of your pocket and have less than the 16 minutes we spent talking about it. What's your take?
Yeah. So for me, I think what I take away from this is that DEXA-ARDS showed in a narrowly selected population of patients without chronic heart or severe lung disease and with early moderate ARDS, mostly from sepsis or pneumonia, that dexamethasone reduced mortality and duration of mechanical ventilation.
Fantastic. Yeah, I think that sums it up. Thank you, Luke, once again for this great walk through the literature. Thank you all once again for tuning in and listening, and we'll see you next time.